organizers of this. Thank you. I'm one of the organizers of this National Journal Club, which is kind of a collaboration between ACEP and SAEM to talk about all things POCUS related. And so this month we are focusing on nerve blocks, which is a topic that I know is near and dear to many people's hearts. So I'm excited to see how all these people here willing to chat about it. I know people are going to be trickling in. So first up, we have an article that from our team at Maine Med, looking at the ultrasound guided Serratus plain block. And so we'll give them a chance to chat about that, and then we can talk about it as a group. And then the second half of the session, we're going to break off into small groups with some small group leaders talking about our second article, which is looking at subdissociative ketamine compared to peripheral extremity blocks for traumatic injuries. So I had lots to say about that one. So that'll be a fun discussion. But unless anybody has any questions. Oh, and afterwards, sorry, we do have a methods consult, I believe, afterwards. So if anybody wants to stick around after the session ends at 3, if you have any questions about your research, or if you want to chat about your methods, or kind of get somebody's ear to run anything by you in terms of your methods, we are all ears and we're here for you. So stick around if you'd like. If there's no questions, I think I'm going to pass it over to our Maine Med crew who, oh, there they are in my corner. I think I see Dave and Christina and Pete, and I can't see who's all the way at the back of the screen, but I think there's, hey, and so we'll let them take it away.
Third best ultrasound fellow.
He's our third, number 3 in the batting lineup. Hey, all, I recognize some folks. For those of you I don't know, I'm Pete Croft. I co-direct our division with Dave Mackenzie over there, the best dressed. Christina Wilson runs our fellowship, and Erik Christensen is one of our 3 fellows this year. And thanks for Nicole for, can you guys hear me fine? Okay. Thanks for Nicole for setting this up. I have the distinct pleasure of talking about our Serratus anterior plain block study. I think, first and foremost, this was a massive study of 20 patients. And I tell you that in some jest, as our goal is 65. I'll tell you, as my first go round, or I guess my second go round in a prospective study. First one was a regional wall motion study. These are really hard to get numbers for. And we'll talk about this a little bit during our brief debrief here. But just enrolling patients in a prospective way, especially when you're doing an intervention such as a block, and you have somewhat limited resources, as we do here in Maine, i.e. we don't have a major research center and research assistants to help us. Those became major roadblocks in enrolling people. And despite doing this for 1.5 years, we were only able to get 20 patients. So unfortunately, that was a bit of a downside of this study just from the start. That being said, we had high optimism moving into it. I did this with my first fellow back in 2018. Our goal was to do a block study that was prospective. So this is the one we landed on. For those of you that don't know, just briefly on a Serratus block, it targets more the anterior and lateral rib fractures that patients present with in a traumatic way, and does not really get the posterior rib fractures. So from a fundamental standpoint, when we look back at it, we kind of wish we designed the study a bit differently, or went and gave us the option of doing an ESP block in addition to this block, because that really took away a lot of patients when we were trying to enroll patients. Those that had posterior rib fractures were excluded. So the one neat thing about this study, and one thing that I would suggest for fellows moving into research, is we did get other people involved, not just in emergency medicine. And this does seem to help with these studies, not only for like collaboration across the hospital, but just in terms of when these patients get admitted upstairs, it seems to be a much more kind of beneficial collaborative process if you can involve people on the receiving end of your patient. So in this case, one of our trauma surgeons was involved in this paper, which was quite helpful. So we have a hospital, it's about 90,000 patients a year. We enrolled them prospectively in somewhat of a convenience fashion. We had about six of us that were enrolling, and there's one of the graphs that we'll go over that shows exactly who was doing the blocks. But in general, we had 3 senior residents, 2 fellows, and 1 attending, myself, doing the blocks. We had a somewhat nominal training period of 1 hour didactic and hands-on, as well as all their core didactics that the residents get, which we touch upon block. So that was basically the background for their proficiency for doing this block. How you got in the study, you had to be greater than 18. You needed greater than 2 unilateral rib fractures that were either anterior or lateral between ribs 2 and 9, and you needed to be getting admitted to the hospital. Once we found inclusion criteria and one of us was around to do it, then became the task of enrolling. And as you know, as many of you have enrolled patients, this is not a quick thing. You know, in general, I think when I talked to Randy, who's unfortunately can't be here today, he's our fellow and the lead author on this. In general, this was probably about a 2 to 3 hour process to get each patient enrolled. And that is, as you know, for busy people with jobs and research and clinician and clinical experience or responsibilities, that's a substantial amount of time. So that just lends itself to speaking to the difficulty of prospective research. What we did once we enrolled patients is we tried to surveil and evaluate their pain. And in doing so, we used kind of a known tried and true method of a pain scale of 11. And we looked at time 0, time 15, and then at 15 minutes, and then time 60 minutes. Now, ideally, we would have liked to look further along. We were using bupivacaine as an agent because it was the most accessible for us and most readily available for our pharmacy. And as you know, that lasts a lot longer than an hour. So it would have been nicer to have a longer term pain evaluation. But just as you can see, we were only able to get 20. The feasibility of being able to get pain scores at 4 and 6 and 8 hours would have been difficult for one person. It would have involved nursing communication, nursing, and oftentimes nursing upstairs, not in the emergency department. And it was just a task that proved too difficult for us. So when we did the block, so that's how you landed in the study. You had to be greater than 18, unilateral rib fractures, and no major distracting injuries. And we left that somewhat vague on purpose, which was actually a good thing. And then we evaluated their pain at those timelines. We also used incentive spirometry to see if we could find some benefit in their ability to pull volumes in regards to assistance with the bupivacaine in the block, if that was proving to be beneficial. And it did seem to be beneficial. And that was one of our secondary outcomes of this study. The main primary outcome was the patient's change in score and pain score from 0 to 60 minutes. That was our primary outcome. Secondary outcomes being the incentive spirometry pull, as well as their pain score at 15 minutes. So in terms of results, we got about 20 patients enrolled. 6 operators performed the block in total. And again, 3 were residents, 2 were fellows, and 1 was an attending. The residents were senior residents, 2nd and 3rd years who had ultrasound experience. And if you look at our figures, you can see that there's a pretty decent amount of improvement in terms of pain scales, as well as incentive spirometry. One thing that we found to be somewhat telling was that, and I think that could have made the data a bit better, was that the patient's pain on average at baseline was not exceedingly high. So I think it was between 5 and 6 on the pain scale. So we weren't starting at an exceedingly high level of pain. So to find a difference at a moderate level of pain is also tough. So when you look at the stats, you need to consider that as well. You're not starting at 10 and trying to get to 5. If you're starting at 6, your goal is probably going to get to 3 to 4. You're not going to probably get to 0. So that proved to be somewhat of a confounder and a difficult aspect of the study. The other difficulty is, as we all know, these patients have either got pre-hospital fentanyl, pre-hospital morphine, or got loaded with opioids on arrival. So in any pain study, and in particularly a block study, trying to skew out opioids is difficult and basically almost impossible in regards to controlling those variables out. So that was something to consider as well in terms of morphine equivalence. Let's see. Let's see. I mentioned some of the difficulties already. I mentioned, so just to go over, pain's hard to assess. Getting it through the IRB was very difficult, harder than I ever imagined. Just getting something through the IRB where you're going to be injecting something into a patient. We really had to talk that through and walk that through in agonizing detail to make sure that there was no complications. And thankfully, there was no complications at all from this study, up to 24 hours from the injection, which is considered safe, especially when using bupivacaine. I mentioned the enrolling time was quite substantial, 2 to 3 hours a patient. Average pain was at moderate scale, so not incredibly high. And I mentioned the aspect of the posterior rib fractures, which I think we can all agree as a group, looking back, was kind of a big deal. So many of these patients have a bunch of rib fractures, many of which were posterior, that were just immediately out of the study. And so that really kind of curtailed our numbers and our goal of 65. We quickly were like, we're not going to get there. And we wanted to produce something. And the data was optimistic and was productive. So we said, let's get what we have out there. And so that was kind of our goal there. As I mentioned, some other tips involving consultants. We involved pharmacy trauma. I know when I did a regional wall motion study, I involved our cardiologists upstairs, and that was extremely helpful. And the last thing is, whenever, like, especially prospective studies, and many of you probably know this, especially the faculty on this call, is like the idea of getting a fellow like Erik to do a prospective study in a 1-year fellowship from like nuts to bolts, from beginning to end through the IRB is absolutely impossible. So, this was a study that we conceived when our fellow was actually a resident, and we wrote it up when he was a resident before he started fellowship, and he actually finished it when he was faculty. He's part-time faculty with us now. When we finished it 2 years after he was done with fellowship. So it just takes forever. It was 20 patients. It comes across as a very small study. It takes a lot of people and a lot of to work to get it done. We were pretty proud of the study. It was fun to do, and it got us much better at blocks. It made it an emphasis in our department, and it really helped with relations with trauma, who actually were coming down asking for us to block patients, which, as you know, is like, if you have that happen, you are just in the clear if you have your consultants asking to do blocks. So that was actually a big win, and that has kind of translated into our program being a much more friendly or a block-friendly program, studies like this. So I think it does pay off in the long run. It just does take a lot of lead time at the beginning. So I think that's all I had in terms of a quick overview of the study. I don't know if you guys had anything you wanted to mention.
Yeah, I think my major points are what Pete has already said, that it was a really great project in a lot of ways, but we met a lot of roadblocks. For us, it was kind of one of the first prospective interventional studies we've done. It's not kind of the typical ultrasound, we can do it, verbal consent study. I think it was a pretty big deal writing up for the IRB, and it was a funded study. And so kind of figuring out how to obtain medications that were not billed to the patient and store them in a refrigerator in a locked office, and obtaining those and keeping track was a very interesting learning point for all of us, and did contribute significantly to the time involved enrolling patients. It was a verbal consent or a signed written consent process, and locked up medications and obtaining all of the needles and supplies from a separate source other than the emergency department. So that was an interesting experience, and I think a learning experience for everybody here. And the other thing was just the choice of block that ultimately really limited our numbers. I think we would have had probably 3 times as much enrollment had we done the ESP block. But by the time we kind of talked about adding that, we had some challenges with our data safety monitoring board and ultimately elected to stop the study. And that was kind of another learning experience. I hadn't really been on a DSMB before. I don't know if you want to speak to that, David.
I think so much depends on your local environment. I think in some ways we might have had a more difficult IRB than some centers, at least for this particular study. The chair of the committee at one point wanted to propose a failed block as a complication. And to Pete's point about having allies, a regional anesthesia specialist from anesthesia was on the monitor. He's like, what are you talking about? Like, that's not a complication. That's like, that just happens sometimes. So I don't know where you are. It's great that you're all on here, and I don't know where you are in your research experience or with doing nerve blocks. Once you start doing this stuff, you have so much respect for people that are doing prospective work in ultrasound, because it's just such a labor of love to be there at the time when these patients arrive. Rib fracture patients don't come in during business hours. They arrive late in the day or in the evening or overnight. Someone's got to be there to enroll them. And then, we have a lot of old people here with hip fractures. And so the fascia iliaca block was just like deeply ingrained into clinical care at this point. And this is sort of, what other things they're neat. It's fun to do blocks. What else can we do? And this was like a natural outgrowth. And someday it'll get folded into some systematic review with as a trivial number of patients. But even just to get this, we powered it for to detect clinical differences based on projected pain scores. We just got nowhere near. They're just given the difficulties of enrollment. And yet you still realize how much work went into it. And at the end of the day, I believe the results. Like when you look at the mean differences and when you look at the patient level differences in the graphics, when people who have relatively higher pain scores, they get more bang for their buck. And of course, would we rather take this out to longer time points, to 8, 12 hours and see how they did? Would we want other clinical outcomes, whether it's downstream infections or other? That would be awesome. We're just not there. I think it is patient oriented from the standpoint is if you can reduce someone's pain, that's a win. And that's it may not be a downstream outcome, but reducing pain is still meaningful, and it's not a totally abstract outcome. So yeah, it was a fun project to do for all the challenges that are involved. I would certainly not let you dissuade this from doing anything with regional anesthesia. I think probably when I think about what probably needs to happen for both Serratus and for ESP, is we probably just need dirtier retrospective data. And Nicole may have something to say about that as well too, just in terms, and just to be able to extract it, because we went big for a prospective series with all that's involved with that. And to just sort of build out the literature to support the case for these, because if you do them, you realize sometimes they work and you get a great result, and other times it didn't work as well as I was hoping it would. But I think to really build some numbers, we need more people to just publish retrospective experiences and not losing sight of prospective studies are great too. It is such a labor of love to do them.
Yeah. And just a couple of the unseen byproducts that are worth mentioning is that I think 2 of the 3 residents that were involved became fellows in ultrasound programs. And this paper got a lot of play both nationally and internationally by the author. He's presented it throughout the world and used it as kind of a launching point to presentations and exposure. So those are the things that, I think those are the things we need to consider when you do put in that labor of love, that you do get a lot of back if you're smart about it, which he was and has used it on multiple platforms to get the message out there and to present and to improve his dossier, et cetera. So, yeah.
Awesome. That's so great, you guys. I can't believe it's so funny. The way this paper reads, you would not anticipate all the challenges you're describing, because it just reads really clean and straightforward and just a really nice example of a very clearly answerable question that you guys were going after. So it's so funny to hear all the different challenges that you were talking about, because it does not read like that at all. I love this paper. And one thing we talk about a lot on this session is how do you design studies that fellows can do kind of in an encapsulated year of a fellowship, right? And at first glance, studies like this feel like, maybe this is something doable, but when you actually do them, you recognize how hard and how many challenges you run into and how long it actually takes to recruit these patients. So I totally love the realistic view that you guys are giving. I don't know, Petra, you've mentioned things like that too. It's actually very hard to do any sort of prospective study in ultrasound, let alone an interventional procedural study that you're going to hit a ton of roadblocks for. I have other thoughts, but does anyone else have anything else they want to mention? Because I have a couple questions too.
I have a question.
Yeah.
This is Bryson Hicks. I'm from the other Portland. Question for you. You mentioned it was really challenging to fit the enrollments, like based on your clinical schedule and everything. For the people that were enrolling patients, were these people who stayed on after shift to enroll a patient? Were enrollments done during a clinical shift, or were these done during like scan shifts, or what was your like time block when you were enrolling people?
Yeah, so a couple different ways, very rarely on shift, just the time, just unable to do that. Scan shifts were one avenue, but as Dave mentioned, for some reason, well, I think we know a lot of these patients get transferred from outside places, so usually land in your ER between like 7 p.m. and 2 a.m. Trauma transfer, 3 rib fractures. I mean, we go over there, clear them, and they go upstairs. That's the run of the mill rib fracture patient, especially in Maine with the ski injuries and so forth that we get. The other thing is that we did have is we have a trauma pager, and Randy got all the pages, and he kept his pager on all the time, which is another bit of it. We like being ER docs because we don't have to wear pagers, but as you know, if you're doing something like this, you have to wear a pager sometimes. So he wore a pager, and he'd get the pages out, and occasionally he lives close to the hospital and would come in on his downtime and enroll patients. So good question.
I think so. And I think this is true of most of the experience that I have, but like scan shifts are probably the highest yield. Because it's really hard if you're working as the attending to sort of be like, I'm going to stop everything, explain a study properly, and then be available to do, in this case, the post assessments, and it's tough. Yeah. So, or you just need that dedication of saying, I'm coming in and going to be around. And to some extent, a fellowship year is a good year for that. Like if you can plan out something far enough in advance, like from the moment you match, if you know something you want to do, or you have something in mind for a fellow, you may get an IRB approved depending on your place, like kind of by midway through the year. If you can be around in the ED every afternoon and that works with your life and schedule, you may be able to enroll some folks.
Awesome. William, yeah, did you have a question?
Yeah, I'm ultrasound director in Montreal. It wasn't a question, more like I'm impressed by your study. It's super hard to do that kind of prospective study. And I feel what's difficult with rib fracture nerve block, it's really different than the other extremities where they don't have any more pain, they feel perfect. Like when I started doing ribs nerve block, I always was a little bit depressed, like, he's still in pain. But then you say, he's coughing a little better, he's breathing a little bit better. So I feel in the end, your study represent that they improve. It's not perfect, but they definitely improve. They get better Spiro, their pain score is lower. So I feel it represents reality that even if they keep having pain, which is different than the other nerve block, it does help them. So we should probably continue to do them. And yes, do the ESP block when it's consequent. So thank you and good job.
I think anecdotally, the trauma service here recognized that the patients who were getting blocks, even if they weren't in the study, were getting benefit because they weren't going to be seen by the pain service for some of the older people with higher risk and more pain, kind of until the next morning at best. And so they started asking, hey, could you do a block for some of these patients with rib fractures, even if they weren't in the study, knowing that there's going to be they were seeing benefit from it. So that's part when I sort of mentioned retrospective data. I would love to see someone sort of, let's see a signal in patients who get a block done, and let's even a case control with ones who didn't, in terms of like length of stay, pneumonia, opiate use, that sort of thing. My gut is it probably acts a little bit like the fascia block, in that better pain control earlier may well lead to better downstream outcomes for them. And it would be fine to even look at that retrospectively to start.
Just as a quick side note, do you block all your elderly hip fractures or only the ones that are in significant pain?
The goal is all. I would say at 80 to 90% typically get done. The goal is all. It became the service line initiative of our orthopedic service for us to do blocks on their patients. Like, you know how every service, us, in the ER have like an initiative every year. Their initiative 2 years ago was for every hip fracture to get a block done by an ED doctor. So
we try to
possible.
offer it to every patient, but not every patient agrees to it.
Yeah. This is a surprising number that say no, either just because they're actually not having that much pain, or just don't want one for whatever reason. But the default approach that we have is everyone should get one.
Hi, everyone. Great study. Sorry, I couldn't figure out how to raise my hand, but I just had a quick question about the study design. When you guys were designing this, was there any thought about making the primary outcome actually be the change in vital capacity? I just found it very interesting to be actually using something maybe more objective. We all know, we've all seen the patient that we block that says like they got zero relief from the block, and next thing you know, it's a, you know, you do your femoral nerve block. Next thing you know, they're like moving around the bed and they're like, you know, getting on the bedpan and they're like, nope, didn't work at all, didn't work at all. And so to me, it's just interesting that you guys had that in the actual study design. And what was, I guess, the thought process behind using it? And was it in part to try to take the subjectivity out of the pain scores potentially?
I loathe pain scales. Like I loathe pain scales, but they're used. And so we wanted to include that. The power calculation here ended up at 65, but we sort of had to do this deep dive to figure out what we thought the mean pain scores were going to be in this population to try and get the calculation done. And we sort of had to fudge it a little bit. So we decided that including vital capacity, as you say, would be an objective thing, because you exactly have that experience too, where someone like it's what they tell you is not commensurate with how they're behaving and how they're acting after the block. So, and you sort of these people, you know, like abscess or like a fracture reduction at, you know, in the extremity, like, I have so much pain, there's no way this is working. And then the arm is like the hands out and stuff like that. It's totally working. We're going to be fine. But I think we just, as you're alluding, we just wanted to add that in to have something objective and also to deal with our challenges surrounding not knowing not having a great handle on what we thought average pain was going to be for this population.
Yeah, that brings up hi everybody, Larry Melniker here, brings up perhaps a bigger issue. I learned a new word a couple of years ago. Many of you may already know it. It's catastrophizing. It's in the dictionary. It's what someone who's, you know, groomed and fed and, you know, showered is doing when they say, yeah, I have 10 out of 10 pain. And given this avenue of investigation, you know, maybe we need to really think about operationalizing other definitions and other outcomes for this patient population. Not sure how to best approach that, but it may be something we're forced to do.
One of the things that recently was published, I think a case series looking at the actual diaphragmatic excursion is another way to look at actual, you know, effect of a serratus anterior nerve block. So it's another way to kind of objectify. Again, I think trying to do that prospectively and having someone go back and try to measure that does not sound like a very fun, or you would need to have some sort of funding for that. I can't imagine it'd be very easy to do that. But I think it just kind of speaks to the point that it is really difficult when we do these pain studies, how to actually objectively find out the effect, right?
Yeah, the other thing that I've been seeing more often recently is the patient experience too, which I know is also subjective, but you can have, what I've been seeing is you can have like minimally changed pain scores, but the patient is thrilled. And so I'm not sure exactly like how you weigh that in terms of the efficacy of the block or the efficacy of the intervention, but it's just another piece of data to kind of incorporate to say, hey, this is maybe not a terrible thing to be doing, even if like we're having a hard time measuring objective outcomes. But I love the idea of downstream outcomes like length of stay, opiate requirement or opiate equivalents needed, things like that.
This is
one question I have.
from, oh, go ahead.
So when you guys were looking at your inclusion criteria, exclusion criteria, what was the thought process around only enrolling patients that were going to be admitted? Because the time course was just 60 minutes post block, and so conceivably that's somebody that you could block, turn around, and get home. Which, you know, for a lot of the younger, healthier patients that have, you know, 1 or 2 rib fractures, you know, the skiers that come in and are just in a lot of pain but are going to be fine. You know, some of those patients were just blocking and sending out.
Our IRB was like really painful, more expected than I thought, and they were afraid that catastrophe was going to befall patients who we discharged. So they only wanted us to include patients that we were keeping, because otherwise, you're right, like the short time frame that we looked at, we should have been able to include people who were sending home if we're only looking to an hour. They wanted to know that we were finding all our downstream problems, which weren't there.
I can comment. This is Lynn Rappold, UT Southwestern. Thank you so much. This has been awesome. I love hearing what really happened. Very nicely done study, great paper, but just because there's so much work that goes behind, you know, what was presented and what we saw. So thank you. And for all of us researchers, just to kind of learn from what you did, and especially for those who are new at research. So I just had a couple of comments. First of all, I love the idea of David that you mentioned of surrogate markers for pain, because pain is so subjective. And I think the vital capacity, for those of you looking for projects, is a good surrogate marker. It's a measurable thing. People can do better if they're not having as much pain. And so I think that would be a very interesting study. I was just wondering, in your study, there was several data points in figure 2 where it looked like there was no change in their pain at all at 15 minutes and 60 minutes. And then there are also some data points below and no change even when they were at their like vital capacity. What happened with those patients?
Yeah, there's actually, I think, 1 or 2 where their pain went the other way, which was when we were doing it, we're like, uh-oh, this isn't going well. But I think it just speaks to the difficulty in the outcome, right? Or the assessment of pain. I don't have a great rationalization of why these folks stayed the same. Maybe the block wasn't done perfectly. Maybe they weren't in the right plane. We saved clips and retrospectively looked at the images, and we didn't have any that looked terribly done. But as you know, if you're not hydrodissecting along the fascia, maybe you're not going to get as much efficacy. I will say that we taught it. I don't know how familiar you guys are with Serratus blocks, but there's a couple different ways you can do it. You can instill the anesthetic above the muscle and right underneath the anterior fascia or the superficial fascia of the Serratus, or some folks will actually go deeper, more towards the pleura. We chose to do it more superficial just for safety, teaching residents and to avoid complications. There's a little bit of signal in the literature that maybe going deeper to the other side of the muscle might be more beneficial. So that might be something to look at. But Lynn, I don't have a great explanation for why those folks didn't change. I will tell you from looking at other pain studies and interventional studies that does sometimes happen where folks just either stay the same or for whatever reason go the wrong way. I think only had 1 person go the wrong way, so that was good. But
I think this is part, so the figure 2, I think, as sort of someone who obsesses over data display, I think if you're doing studies like this, a spike plot that shows individual patient level directional change is so helpful to understand and helping understand the data. So some of what you're getting at, if you look at where those patients are, their pain scores are all under 2 to begin with, or they're around 2. Like, it's hard to budge them. Like, maybe we did a crummy block, like maybe, but like, it's hard to move them.
yeah,
Whereas when you look at where the green arrows are and their pain scores are coming down, those are all people who had more pain to begin with, the population you really wanted to target. And then when you look in panel B, the sort of lower panels, you can see that 60 minutes later, those patients actually now have higher baseline scores. So at 15 minutes post-block, their pain is like at rest is lower. Now they're reporting higher baseline pain, but their like blocks have gone down, or they're getting more effect. And then you can also kind of map them to what happens a little bit with some of the incentive spirometry scores, which are a little bit harder to interpret. But I think some of that, honestly, it's just because they were low to begin with. And it's just hard to move their envelope.
Thank you.
All right, guys, this is a great discussion. We're already over, but if anybody has more comments, we can certainly keep going because this is all great and kind of good like group think on how to get these nerve blocks more into the ED and how to make them effective.
I just wanted to give a shout out, especially to young investigators. I put it in the chat. When Focus World Symposium in December this year will be devoted to POCUS guided procedures and interventions. And there will be sort of a citizen's choice of one track of the program. So anyone interested in demonstrating, teaching a procedure, there'll be a research forum. Anyone who's interested in this can shoot me an email, and I'll make sure you're on the listserv and know the dates for these submissions for any interested parties.
Perfect. Thank you, Larry. We appreciate that. Before we start to break out into our small groups, I wanted to thank Maine Med team for coming and for sharing kind of all their wisdom on this study, because this was really great, and we really appreciate your effort and also, you know, helping us keep doing more blocks in the ED. While Dan is getting the groups ready, I just wanted to also give a plug. We're creating a national database of nerve blocks performed in the ED. And so we've got kind of a collaboration of up to, I think, 10 sites it is right now, where we have a protocol and we're pooling data from all nerve blocks performed in the ED to kind of do a multi-center sort of collaborative effort to demonstrate things like safety, efficacy, to really kind of push these over into a space that is kind of widely accepted. And so we take all data, we take all comers. So if anybody's interested in joining kind of this national collective, please reach out to me anytime. We can talk more about how to get you involved. But things like this, where we're all kind of banding together to make blocks a more acceptable and a safer and a more effective kind of practice is always wonderful.
Yeah, this is very timely. Politically, I've had a blessed career. I've never had a radiology chief that was in my face and giving me a hard time about POCUS. But I am part of New York Presbyterian, which is a 10 hospital system. It's actually now a 9 hospital system since Methodist is officially part of New York Hospital. There's a whole bunch of work being done on standardization within these large networks and enterprises. My department is one of the few that does nerve blocks. So a standardized protocol for POCUS at NYP, you know, it would not logically include nerve blocks because all the other sites don't do them. Our anesthesiologists had certain privileges removed by the mothership because they didn't want to do them at Cornell. So it is essential that we get this database completed and demonstrate full-throatedly that this is standard practice in the specialty of emergency medicine.
Sounds good, guys. I'm going to open up the room. Since we're a little over time, it's going to be about 15 minutes instead of 20 minutes. If you need anything, come out to the main room, grab me. Otherwise, I'll see you guys on the other side. Thank you.
Thanks again.